Welcome to our live webinar titled Cutaneous GvHD, Diagnosis and Treatment. Thank you for joining us. My name is Alice Hauk, Senior Director of Professional and Patient Services at the Aplastic Anemia and MDS International Foundation, and I will be moderating the presentation today. As we get started, we recognize the generosity of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the webinar today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the webinar. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation. To submit a question or comment, open the Q&A window on the lower part of your screen, type your question in the small text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do 2 things to help us manage incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Edward Cowen. Dr. Cowen leads the NIH Dermatology Consultation Service, conducts independent and collaborative research, and oversees a continuing medical education accredited dermatology grand rounds, branch clinical fellowship, and resident education programs. He is an internationally recognized expert in cutaneous graft versus host disease and serves as director on the American Board of Dermatology, as well as on the editorial board of JAMA Dermatology. Dr. Cowen's primary interests include chronic graft versus host disease, primary immunodeficiency, autoinflammatory skin disease, cancer genodermatoses, and adverse drug reactions. As a founding member of the NIH Chronic GvHD program, Dr. Cowen has authored more than 50 original manuscripts and chapters related to the disease. His current research interests include novel treatments for skin fibrosis and objective measurement tools to assess disease activity and response. With that said, welcome, Dr. Cowen.
Thank you. And thank you, Alice, and to the Society for the invitation to speak to you today. So I'm going to share my screen and hopefully this will be successful. Let's see here. All right, is this full screen for everybody? Speak now or forever hold your peace. All right, I'm going to assume it is. So I'm going to talk to you today about the various cutaneous manifestations of GvHD, and then a little bit about treatment and what we're doing to try to better understand and help patients with chronic skin GvHD. For those of you who aren't familiar with the NIH, our main campus, the mothership, is in Bethesda, Maryland. There's 100+ buildings on campus, and it is primarily a research enterprise, but there is a hospital. It's not called the hospital, it's called the NIH Clinical Research Center, and patients are seen there on research protocols only. So it's a little bit different than your typical academic referral center. There has to be an investigator who's studying or interested in the specific condition for which you're struggling. So the bone marrow unit is located here, and the clinics are located in the black building that's sort of adjacent to what was the older version of the hospital. And so we're very closely approximated to the bone marrow unit. And this is different than at some transplant centers where the dermatology clinics may be actually located off campus or not even in the same general vicinity as your transplant centers. But what that means is that it's very easy for us to see patients quickly and evaluate them. And so we've evolved into a nice relationship over the years, including a multidisciplinary group that I'll talk to you a little bit more about as we go on. So when thinking about skin disease in GvHD as a dermatologist, I'm acutely aware that there's differences at other medical centers in terms of what the role is for dermatologists and skin involvement. And so there are certainly some centers around the country where the vast majority of care, including all of the skin care, is performed by the transplant team, including even skin biopsies. The other extreme would be where we've got dermatologists that are actually responsible for the extracorporeal photophoresis units at the transplant center and are fully integrated into multidisciplinary management. And so obviously the NIH is at one end of the spectrum, but most places are somewhere in between. So dermatologists are maybe involved intermittently to help make the diagnosis. They may make recommendations about skin-directed topical therapies or help with wound management or skin infections. But I would say most of the time, the decisions regarding systemic treatment are usually going to be deferred to the primary transplant team. So I'm not going to spend too much time on the biology of graft versus host disease. I think this is probably pretty well established for most of you, but you have about a 25% chance of being a full match with a related sibling. And so the number of siblings you have makes a big difference in terms of the likelihood of you having a match. The US is actually ranked 142nd in terms of the number of children per capita that families have. And even patients who are quote unquote full match, there's still a 40 to 50% chance of developing graft versus host disease. And we know that this is at least in part to other non-major HLA antigens, such as the HY allele. And so the scenario that you would ideally want to have after transplantation would be to have an identical twin. For most of us, that's not the case. And so you want a matched related donor. And if you are a male, you want to have a male donor because they'll be less likely to have antigenicity against the HY minor allele. On the other hand, many of us have to go through mismatching or unrelated donors in order to get a transplant. And then if you're a male, it would be more likely to have issues if you have a female donor, particularly if your donor's had multiple boys, because then she's very likely to have developed an autoimmune HY antigen. So what is the scope of the issue? So lots of transplants are performed every year, but the number of unrelated transplants continues to rise. And so it's expected that the number of patients who are dealing with complications of GvHD after transplant is continuing to rise. And in fact, GvHD is second only to recurrence of primary disease as a major cause of death after transplantation. In the acute setting, there are three major organ systems that are affected. The GI tract, usually presenting with abdominal pain and copious diarrhea, liver involvement, which presents with liver function test abnormalities, and then skin involvement. And the skin involvement can range from a sort of non-specific pink rash to generalized full body redness, and rarely patients can have what's called necrolysis, where the skin actually separates from the body. And this is obviously very uncomfortable, but also a very severe manifestation and a poor prognostic factor because it's very difficult to maintain fluid hemostasis, to prevent infection, and to control this form of skin GvHD. The skin is one of the organs that's most commonly affected with GvHD. It's second only to mouth, depending on which type of study you look at. And often mucosal disease goes hand in hand with skin involvement. And we'll show some examples of that as well. But there's lots of different organ systems that can be involved. And this is why managing chronic graft versus host disease is such a challenge. It's hard for the transplant doctor to be an expert in all of these areas. And this is really why it begs for the use of multidisciplinary approach when possible for patients who are dealing with more than one organ system involvement. So how do I think about skin GvHD? There's lots of different terms that are used, and it's valuable for those of us who sort of are enrolling patients on clinical trials to know what these terms mean, but for the purposes of patients, the way to think about this is the skin GvHD primarily involving the upper layers of the skin, what's called the epidermis, or is it involving the dermis, which is basically the collagen-containing middle layer, or is it involving the subcutaneous layer, which is the fat? And the way these different layers are affected will also affect the way it looks clinically in the skin. And so I'm going to go over what these sort of different forms of rashes do actually look like. There are actually lots of other diseases that mimic what chronic graft versus host disease can look like in the skin. And so these are some of the names that, again, outside the scope of what you need to know, but just to show you that there's really a very wide spectrum of skin involvement, and one person's GvHD is not the same as another person's. So as part of the effort at the NIH to try to begin to study and treat patients more effectively, we came up with criteria in order to make a diagnosis of chronic skin GvHD. And this was done in every organ system, but I'm just going to focus obviously on the skin involvement. And so the features that are considered diagnostic are those manifestations that in and of themselves are distinct enough that without a biopsy, you can make a diagnosis of chronic graft versus host disease. On the right-hand side are the distinctive features, and these are the features that also can certainly occur in the chronic GvHD setting, but they can also be associated with other processes as well, such as drug reactions or other phenomena. And so the presence of just pigmentary change or non-specific scaling rashes, you can't make a diagnosis of GvHD unless you do a biopsy to prove that that is what you're dealing with. So one of the most common manifestations that you may have heard is called lichenoid GvHD. The term that I prefer is actually lichen planus, like GvHD. Lichen planus is a skin disease that occurs outside of bone marrow transplantation, where people get very itchy purple papules. It tends to occur in the skin, the genital mucosa, and the oral mucosa. And so this disease of lichen planus is very similar to lichen planus-like graft versus host disease, because all the same organ systems can be affected. When it's on the skin, often it will have a sort of interconnected, or what we call a reticulate pattern, with overlying redness and scale. And because the inflammation is happening at the basal layer of the skin, the pigmentation layer often will drop down, causing this chronic pigmentary change even after the rash itself is resolved. And this is what we call post-inflammatory hyperpigmentation. Another form of diagnostic GvHD of the skin is called poikilodermic changes. And here you have redness, but you also have light colored skin and hyperpigmentation and atrophy. And this resembles what we see in autoimmune diseases like lupus and dermatomyositis. Excuse me. Papulosquamous changes are changes that are considered not to be diagnostic. And so this can look like psoriasis and eczema. These are patients who have GvHD, but you would need to do a biopsy in order to confirm that's what you're dealing with. And this is called ichthyosiform chronic GvHD. And so in this case, you have what just looks like very dry skin, like you might see on the lower legs. And again, you would need to do a biopsy in order to make that diagnosis. This is called keratosis pilaris like GvHD. So what you see on the front of the legs here are just prominent little hair follicles. And in the closer up image, you can see little dollops of scale. And this corresponds to where the GvHD involvement is preferentially involving the epidermis near the hair follicle. And this is often an early sign of GvHD before more widespread skin rashes develop. Nail changes are also very common in GvHD, and this can range from just brittle nails, nails that split easily, to people who will lose their nails altogether. But this is not a diagnostic feature because this can follow chemotherapy or thyroid disease or even nutritional abnormalities. Now I'm going to move on to the diagnostic features, which are actually associated with skin thickening. And these are called the sclerotic features. And even though we usually don't think of skin disease as being a major cause of death in patients who have chronic GvHD, it's a major quality of life issue. And so the fibrosing manifestations cause severe morbidity for patients ranked second only to lung manifestations of bronchiolitis obliterans. So what does this look like? So basically the skin will look shiny, it'll feel tighter, and depending on where the fibrosis is located, you may have loss of function of your joints, you may not be as flexible, or you may not feel like you can get as deep of a breath as you normally would. You actually have to lay hands on the patient in order to make this diagnosis, because there may be a lot of pigmentary changes that look like skin activity, but you have to pinch the skin and actually qualitatively determine that the skin is not its normal flexibility. And so here's an example of this patient has lots of pigmentary change where the skin is lighter and darker, but you actually have to sort of pinch, and that's where you can determine in the red area there, the skin is actually thickened, and in the blue area, the skin is normal despite the color change. A deeper form of this process is what we call subcutaneous GvHD. You may have also heard the term fasciitis, and that's the same process. So now the thickening is not just in that dermal middle layer, but down in the subcutaneous fat. And the thickening of the bands of tissue around the fat lobules are what leaves you with that lumpy, bumpy appearance. So patients may actually think that they're dealing with cellulite because of that lumpy appearance and the fact that they're on steroids and lots of other reasons they might develop cellulite. But in fact, this is an insidious form of GvHD that's deeper down, and you may not have the overlying color change that you see with some of the other forms that I just showed you. You may see a prominent grooving or sort of lumpy nodularity to the skin. This patient has some hair loss on the wrist over an area where the skin is more bound down. And it can be very subtle. And so people may not notice this. If you stretch the arms or legs, then sometimes you'll see an accentuation of these grooves. And this is called the groove sign in fasciitis. It can be along the path of superficial vessels. It can be in the back of the knees or along the fascial bundles on the wrists. And this is a sign that there may be fibrosis that's happening deeper down that you may not be aware of. And if patients have significant involvement of these deeper tissues, you can actually be left with contractures where you lose function and flexibility, but the overlying skin actually is okay. So if you look at this patient, you can see there's actually normal hair growth. There would be normal pinchability of the skin, but they have a contracture because of the fascia around the tendons and the deeper tissues are tight. And we demonstrate this by having patients do a prayer sign, and the inability to sort of fully extend the fingers and wrists demonstrates that these deeper tissues are being affected. This is an example of a woman who had involvement of her abdomen and had just attributed this to cellulite, but she's actually, her skin is sort of pulled tight, almost like a girdle from this deeper tissue rippling. And this is obviously a less common area for you to develop cellulite as well. And so when we look under the microscope at these patients, if you look at the top here in the dark purple, this is normal epidermis. In the middle is what the normal collagen of the epidermis. And then it's down in the deeper tissue here, as you get closer to the subcutaneous fat, where the pink tissue becomes bubblegum colored and almost blends together. You don't see the separation of the fibers. And this is what's called homogenization. And this is what you see with sclerotic skin diseases like GvHD and scleroderma. When patients are first developing this form of skin fibrosis, they may notice that there's color change or tightness in certain areas of the body. And one of those areas is the waistband area. Another is the bra band area in women. This is called the isomorphic response. And so subtle friction or pressure is enough to induce the development of GvHD preferentially in these areas. And so it's important to sort of have your doctor examine these areas, and for you to feel if it feels tight and not just pigmented, then that suggests that there's actual skin thickening that's occurring there. And here's a few more examples. In some of the pictures, you can perhaps see the shininess to the skin, and that refractiveness is a one way in a skin image that you can tell that the skin is tighter and fibrotic. Fibrosis can also preferentially develop at sites where there's been other skin injury. So this is the medial aspect of the arm where you would get your blood draws. And so repeated blood draws can do this. This is on the side of the neck where people would have a central venous line access. And you can see the small scar from where the line would be, but a much broader area of yellow thickened skin. And so the fibrosis developed initially near the line, but has extended into a larger plaque. Now, I don't use the term scleroderma because that's an autoimmune disease, and that is different than the skin fibrosis that we see with scleroderma like GvHD. Systemic sclerosis or scleroderma occurs almost exclusively in women, and it's associated with very specific autoantibodies. And so the GvHD type of fibrosis that we see doesn't have that same predilection for females, and we don't see that autoimmune specific findings. And so I use the term sclerotic type chronic graft versus host disease, but you may hear people say scleroderma like GvHD. Just, it's important for you to understand that it's not the same disease as scleroderma and has a very different natural history and outcome. One of the things that is very common in the autoimmune disease known as systemic sclerosis or scleroderma is that the fingers become very tight and tapered. That's called sclerodactyly, and we really don't see that in GvHD. This is a GvHD patient. You can see the white skin here. This is where there's fibrosis, but the fingers are actually normal, and this is much more common scenario for what we see in GvHD. There may be contractures, but often it's because of the deeper tissues rather than that tightening of the fingers themselves. Morphea is another type of skin disease that really closely looks like what we see in GvHD. Morphea is also considered an autoimmune disease. It doesn't have the same autoantibodies that you see in scleroderma, but you get localized patches of involvement. And so on the bottom left here is an example of a woman who has a man who has a tight plaque. And then on the right, two examples of morphea like GvHD, where you have localized areas of skin fibrosis. And there's also a form of this disease called deep morphea. And this really, in my mind, is what most of our GvHD patients look like who have widespread involvement. So you may have plaques where the skin is very tight, but often the skin is just irregular and has this lumpy, bumpy look. And that's because of that deeper involvement of the subcutaneous tissue and fascia that I discussed. One skin finding that we see in patients who have long-standing skin thickening is the development of these little red nodules. They look like little collections of blood under the skin or little blisters, but they typically will stay intact. And this is what we call GvHD-associated angiomatosis. And so these are, in fact, vascular proliferations, but they're benign. It tends to occur in long-standing skin tightness, particularly on the lower extremities. And as long as they're not growing rapidly or changing in an aggressive way, it's okay to avoid biopsy because obviously fewer biopsies of tight skin, the better when it comes to skin healing. Another sign you may see in chronic GvHD is vitiligo or alopecia areata. Vitiligo is where you lose pigment from the skin due to an autoimmune cause, and alopecia areata is where you lose hair. And this can be generalized or it can be circular patches of hair loss. And so this is thought to be immune dysregulation locally in the skin that's targeting these specific hair follicles or pigment producing cells in the skin. I'm not going to spend too much time on mucosal disease because we're focusing primarily on skin today, but it's important to consider the potential for genital involvement in women and in men. And in my experience, a lot of times this goes undiagnosed because the transplant physician may not focus on this and certainly may not do an examination, and women may be less likely to offer symptoms unless they're specifically asked about this. So in just one study I'll highlight here, in women after transplant, genital involvement was found in half of the women, but the really interesting finding was that 23% of the time, women had just genital involvement. So even if you're doing well overall and you don't have other signs of skin GvHD or oral GvHD, it's possible to still have skin involvement, genital involvement that's gone undiagnosed. And genital involvement can range just from erythema and fissure formation to scarring and complete agglutination, where basically the external skin becomes scarred down and completely occludes in patients who have long-standing involvement. Genital involvement in men is even less well understood. Again, I'll just cite one study with 155 men after transplant. In this study, 21 of these men, or 13%, had inflammatory genital involvement. And so again, something that men may not offer up, particularly uncircumcised men. This can be a major issue because if it becomes painful or difficult to retract the foreskin, then scarring can actually become quite an issue, and circumcision as an adult is not typically something that people are excited about having to do. And then I want to just mention wounds, because this is a real difficult challenge for patients, particularly those who have skin thickening and long-standing fibrosis of the lower extremities. The goal is to try to preserve and keep the skin intact to the extent possible, because once you develop a wound, it can be very difficult to close. The circulation is diminished, the lymphatic return is diminished, the nutrition to that part of the body is diminished, and patients are usually going to be on immunosuppressive medicines and other things that put them at very high risk of infection. So the more you can protect the skin in areas that, particularly if you're an active person and people are bumping into your legs, or animals are scratching your legs, the more you can keep those protected and prevent skin breakdown, the better. I don't have any one particular great cure for chronic lower extremity wounds. You want to rule out the potential for infection or other causes. There's a variety of dressings and biologic substrates that can be used now to help expedite healing, but really it's typically going to be compression and time and a lot of gentle wound care measures. If possible, if you can get to a dedicated wound care clinic, they can help with some of this, and generally the outcomes are better if you have someone who can help you manage the wounds on a regular, ongoing basis. All right, so moving on to therapy now. So what about non-prescription treatments that you can do? So emollients and moisturizers are a great idea for all patients who are dealing with GvHD. It may help with itching. Certainly it'll help with that dry, flaking skin. And it's a good idea to help keep the skin intact, particularly in the lower extremities. Ointments or petrolatum or Vaseline-based products, those are going to be the most moisturizing, but they're also going to be the greasiest. And so using them once a day at night when you don't mind being a little greasy, or if you're putting it on your feet, you can put socks on and you don't mind the socks getting greasy. That can help, particularly if you've got, focal problem areas. Creams are sort of in between, and then lotions are water-based. Those go on very easily, absorb well, but they're not going to last as long. So most people do lotions for the face, but hopefully if you can do at least a cream, if not an ointment, for other areas that are active on the body. What about itching agents in particular? So there are over-the-counter forms of things called hydrocortisone or pramoxine. There's also menthol-based creams that smell like menthol. One's called Sarna. And these agents provide temporary relief for itching. Generally, they're very safe and well tolerated, especially if you don't mind the smell of menthol-based products. And so these could be very useful if you've got a problem area, and it's always better to apply a topical medication, sort of rub it in rather than to scratch at the skin, because you don't want to make a portal of entry for infection. And then you can think about things like antihistamines like Benadryl or diphenhydramine. These are certainly beneficial, particularly to help people sleep at night. Their antihistamine effect is probably not fundamentally going to treat the itch associated with GvHD. The benefit is probably more because they're sedating. And so at nighttime, they may help you sleep. But you have to be careful, because antihistamines can also give you dry mouth and dry you out and make your symptoms somewhat worse. And for some people, Benadryl and these medications can actually cause some CNS mental status changes as well, particularly if you're on lots of other medicines. Okay, what about prescription treatments? So topical steroids are the gold standard treatment to try to control skin inflammation when possible, so that you don't need to be on systemic treatment. So if you've got a localized area of skin GvHD and no other organ system involvement, it's always going to be safer to try to calm down that skin involvement with topical steroids instead of taking prednisone or other immunosuppressive treatments. The problem is long-term use with high potency topical steroids actually will thin out the skin. And over time, you'll just seem that it'll tend to lose some of that strength. You never want to use super high potency steroids. These are called class 1 steroids on the face or in the groin area or in the underarm area. Because these steroids are so strong, they'll actually induce stretch marks. Many patients already have stretch marks because they've been on steroids or they've had weight changes with their previous treatments. And so you really want to avoid steroids when possible to these sort of higher risk areas. You may have heard of a medication called Protopic or tacrolimus or Elidel, that's pimecrolimus. These are topical immunomodulator medicines. They're calcineurin inhibitors. And so they also work as anti-inflammatory agents. They're both prescription agents, but they don't have steroids. And so these agents will not cause skin atrophy. They will not cause stretch marks. And so these are really the go-to agents if you've got GvHD activity in the face or the underarm area or the groin area, and you want to be careful about using steroids. These are going to be your better choice. So if you think you may have increasing skin activity, you obviously want to talk to your transplant doctor, talk to a dermatologist if they're part of your care team, and you will probably get additional questions. And the goal is to really determine if the skin is active and what other organ systems are active as well. So the scenario in which I most frequently will see people who are having flares of their skin GvHD is they've been doing pretty well and their long-term immunosuppression is being tapered. And it's at that point that then their GvHD will start to flare once they hit a threshold dose of their prednisone or whatever other medications being tapered. Many patients who are on extracorporeal photopheresis are on treatment long-term. It's difficult for them to know if they're benefiting or how much they're benefiting, but then when they stop their treatment or if they have to hold their treatment because of a line issue or infection, sometimes they'll flare in that setting. People may sometimes require donor lymphocyte infusions. So if their cancer has recurred or their counts appear to be dropping, if you receive additional donor lymphocytes, that's a common scenario. And then people who just become sick. So if you're hospitalized, if you've had a recent infection or even a reaction to a medication, these are all things that seem to be able to flare new skin involvement. And then what I do is I ask people about other symptoms, to determine whether or not there's any activity going on of other mucosal surfaces, such as oral ulceration or eye symptoms. Ask about GI symptoms with diarrhea, bronchiolitis obliterans, obviously a very important manifestation if people are developing shortness of breath. And then features that people may not associate with skin involvement would be cramping, edema of their hands and feet. This is actually a sign of very early onset skin fibrosis. So before the skin is tight, it'll get puffy and actually retain fluid. Obviously, if you notice decrease in your flexibility, people may just attribute that because they've been out of shape or haven't been feeling well, but it could be because the skin is getting thicker and it's just happening in a way that you haven't noticed it. And then the isomorphic sclerosis that's that involvement of the waistband area and the bra band area. You want to look there and make sure that there's nothing that maybe has been missed. It's important to protect yourself from ultraviolet radiation. And so for all patients with GvHD, recommend sunblocks and sunscreens. You should be getting your vitamin D tested as part of your regular blood work. And if your vitamin D is low, then you can take vitamin D supplementation. Obviously, you can supplement your diet as well. But patients are at risk of skin cancer because of the dysregulation with GvHD, the previous chemotherapy, and the ongoing immunosuppression, which we know puts patients at much higher risk of developing skin cancer. I recommend zinc and titanium preparations because these are mineral-based and they aren't going to be absorbed. And so just look for anything that has zinc or titanium in the ingredients. We have actually seen a number of patients who were sent for flaring skin GvHD, and they were actually developing phototoxicity. And this is a reaction from medications. One of those medications that commonly does this is called voriconazole. And this is a photosensitizing drug that's used as an antifungal agent. And so not all rashes that develop in the post-transplant period are necessarily GvHD, and another reason to protect yourself from the sun. And then having said that, One of the treatments that we do actually use for patients with GvHD sometimes is called phototherapy. And so if you're not on a photosensitizing medication and your GvHD involvement is pretty much limited to the skin, phototherapy can potentially calm down that skin inflammation. You will still have the risk of developing skin cancer, and not everybody is going to be a good candidate for phototherapy. But again, if you have skin-limited disease, particularly widespread involvement, then this is an option. And it's a little bit different than your normal tanning booth. You're going to stand up, you're going to protect your head and neck area, typically wear goggles, and you're only going to be in there for a few seconds, up to a minute or two. So it's a very highly regulated, high dose of ultraradiation for very short period of time. So even people who aren't very mobile are able to stand usually for a minute or two to have phototherapy done. You have to do it usually 2 to 3 times a week, and it's available in most dermatology offices, but not all dermatology offices. So you have to sort of find out if it's offered with your local provider. So the way I think about managing skin GvHD is, so this is sort of my mental thinking. So is the involvement tend to be generalized or localized? And then is the skin the type that's thickened or not thickened? And then if they're thickened skin, is it limited just to the skin, or do they have multiple different organs that are involved? For instance, if a patient's got a localized area where the skin is thickened, then that might be a patient who's a good candidate for phototherapy. But if they have multiple areas of involvement, multiple other organ systems, then they're probably going to need to be on systemic therapy as well. And those are the patients that you'd also want to consider as a clinical trial enrollment. One other thing I want to mention before we sort of leave the skin features is that in skin of color, the pigmentary changes can be a major quality of life issue. Even after the GvHD may have, the activity may have improved significantly, the persistent color change can be a major issue. We did a report where we looked at 40 patients with skin of color, and even though the patients who did not have significant skin activity, but just had pigmentary changes, they actually rated their involvement as being quite severe, almost as bad as having skin fibrosis. And this was very different than how the dermatologists scored their involvement. So the impact of pigmentation, even for people whose disease is not active, can be a big quality of life issue that we shouldn't ignore. All right, I'm not going to spend too much time on systemic treatment since that's a little bit outside the scope of our talk today. Systemic corticosteroids are really the only initial first-line therapy that's approved. However, a number of agents have come out in the last several years as steroid refractory or second-line approved agents. And so the good news is there are now more options available that are actually proven to work for acute and chronic skin GvHD. And those include ibrutinib, ruxolitinib, and belumosudil. Oral ruxolitinib is one of the most popular, used now for both acute and chronic graft versus host disease. On the right, you can see here improvement after several weeks of treatment. But because this is a systemic medication that is an immunomodulator, there is the potential for infections, including activation of CMV virus in both the acute and chronic setting, and it can also lower blood counts. And so these are the downsides of having to take a systemic treatment for a skin issue per se. Interestingly, there is a topical form of oral ruxolitinib that just came out in 2021. It's FDA approved for atopic dermatitis. It's called Opzelura. So lots of people are interested in whether or not this would have potential benefit for skin GvHD. We actually had a trial at the NIH that we had to close due to slow recruitment during COVID, but there is actually an ongoing trial with the topical form of ruxolitinib, and this is located at Sloan Kettering in New York City. And so if you have skin involvement and you're interested, my understanding is they're still recruiting a few additional patients, and you can help us determine whether or not this is a useful additive topical treatment for patients who have skin involvement. So this is a couple years old now, but this is I thought a nice way to think about for acute and chronic skin involvement. You can see skin on the far left panel of both the blue and yellow fields here. what these authors consider to be sort of first-line options, ruxolitinib and ibrutinib in the chronic setting, and then photopheresis and rituximab as salvage treatments. But there is still much we need to do to improve the evidence to have specific agents for specific forms of skin involvement. So why have we struggled to really develop ideal treatments for patients? Well, as all of you know, GvHD is relatively rare, and so your local provider may or may not have a comfort level with skin involvement. Usually when people develop chronic disease, it's a year or two out and they're no longer being seen at the transplant center regularly. When they have multiple organs involved, it's difficult to have multiple different experts, and we've gone over how many different skin presentations can occur. And so when we're trying to do trials to determine better treatments, one of the issues is that we don't really have outcome measures to determine what improvement really is. And we also just don't understand the pathogenesis of the disease very well. So here's an example of a patient who was receiving photopheresis. You can see on the top, very tight, little small nodules in the skin. And then after several months of photopheresis, the skin is improved. But how do you adequately qualify and quantify the degree of improvement here? This can be really difficult and really subjective to do, particularly if you haven't seen this patient for a while. So one of the things we've been interested in is using magnetic resonance imaging to objectively assess the level of skin involvement and the depth of involvement. And so what we did is we actually developed a scoring system for the skin and subcutaneous layers of a tissue. And you can see that here. And what we found is for patients who have skin fibrosis, they actually typically have much more involvement that goes beyond just the skin. That goes down to the deeper tissue, even the muscle. And so really what you're seeing when you're seeing skin tightness is the tip of the iceberg, but the fibrosis goes deep. And for those of you who are dealing with fibrosis, it may not be a surprise to you that it often will affect the deeper tissues and muscle as well. Here's an example of, it would be difficult to quantify, the depth of involvement, extent of involvement, but you can see as color change here and maybe a little bit of induration in the skin. But when you do MR imaging, you can see here a complete loss of the bright yellow, the bright white signal. And so that's loss of subcutaneous fat. And so it's been replaced by thicker collagen. And then this is what's called stir-weighted imaging. And what this bright band does is it's actually showing inflammation. And so it can help us determine there's still activity happening here with the use of these adjunct images. Another example of a patient who is very difficult to quantify involvement of the medial leg here, but with imaging, we can see that the septae are thickened, consistent with that subcutaneous type of involvement. And again, with stir-weighted imaging, we can see there's actually still inflammation going on there, even though you can't see that on the surface of the skin. And we've even detected muscle inflammation, what's called myositis in patients who were not aware that they had this involvement. Another tool that we're using is called a durometer. This has a little tip at the end of it, and you just press the device on the skin, and it allows you to determine how compressible the skin is. And this gives you an objective number from 0 to 100 to determine how pliable the skin is. And ultrasound is another tool that can be used, so to look directly to see the thickness of the dermis here. So this is a patient in their normal area, and then you can see the thicker dermis as manifest by the signal in the lower panel. And so I think depending on the type of skin involvement and where it's located, all of these tools can be helpful to your transplant doctor to determine whether the skin is active, how much activity is present, and ultimately to determine how much you're improving or not improving with treatments. And so you can use range of motion if you've got tightness over a specific joint. You can use ultrasound or other imaging modalities if you can reproducibly check an area over time to see if there's been significant changes. And then the last thing I want to just point out is, we focus on medications in the medical field, but particularly for patients who are dealing with skin fibrosis, there's a lot of other adaptive measures that are out there and that your transplant doctors may not necessarily be aware of, and your dermatologist may not necessarily be aware of. So we recently published this summary of other interventions that could be used to try to help patients who are dealing with the chronic limitations associated with skin thickening, what we call sclerotic type graft versus host disease. And I want to just sort of focus here on the supportive care measures. These are some of the things that can be done in addition to the medications that you're going to be getting to try to treat this form of the disease. So, physical therapy measures, adaptive devices to help you reach things and put on your socks, massage, deep tissue massage, paraffin wax, compression garments, all of these things to try to maintain functionality and ultimately improve quality of life. And then this is just an example of some of these adaptive measures that can be used that are out there. Occupational therapists and physical therapists are aware of these, but if you don't know to sort of reach out and get these resources, then it can be harder to identify them. So starting with a good occupational therapist or physical therapist that your transplant doctor recommends is where I would start with here. And so I'm going to close there. I'm a small part of a big multidisciplinary group, so it's been a pleasure seeing patients with GvHD over the years, but really it requires a team approach. I think that's really my take-home point, and hopefully dermatology can be a major part of that when needed. But the best care really requires input from everyone to come up with a plan of care that's individualized and to optimize your health. And I will stop there, and I'm happy to take any questions if you have them.
Thank you, Dr. Cowen. We will leave it open a few more minutes for questions. One question I have is, you had noted several signs of a potential flare that for someone who's had cutaneous GvHD or is concerned that they're having a flare again. What should they do when if they have any of those conditions that you noted? And should they contact their dermatologist first or their transplant doctor? What would you suggest?
Yeah, so great question. I think both would make sense. So, depending on if you already have care with the dermatologist, then usually it's easier to get in quickly to see them. And so they can take a look and say, does this rash actually look like flaring involvement? Some of the more subtle signs, edema or a tightness, those sorts of things, it may not be as readily apparent on the skin. And so if you've got a dermatologist that has some experience with GvHD, hopefully they can still help you. But really, I think, the take-home point, no matter who you call, is, be proactive. Don't ignore those signs and symptoms. Call, even if it's your transplant team, the nurse or someone, get them in the loop, tell them what your symptoms are. Hopefully they can be reassuring. They can say, well, we can attribute this to your new blood pressure medicine or something else. But if not, then they can basically try to get you evaluated sooner rather than later, and then you're going to be much more likely to respond to treatment when things are in their active phase. Once the fibrosis is there, once these changes have set in, there's still some reversibility, but it's a much slower process. And so, being your own advocate, being a squeaky wheel, getting that evaluation and getting someone to lay eyes on you to make that diagnosis sooner rather than later is probably the most important thing.
Good advice. Thank you. We have another question. Is GvHD in the neck and throat area common?
So I'm not sure if they're referring to sort of esophageal involvement or the skin and soft tissue of the neck.
Yeah, that they didn't specify. So
yeah, so I'll answer both. So
okay.
Skin involvement certainly can occur. The head and neck area, fortunately, is one of those areas that's less common. One of the things we don't understand is that despite all of the weird areas it shows up, the head and neck, at least for skin tightness, is pretty uncommon. And that again contrasts with like scleroderma, where people get very tight, around the nose and mouth very frequently. That's one of the most classic features. It can occur in GvHD, but it's less frequent. And the same with the neck. The knees and elbows, same thing. That skin tends to be protected. But when it does occur, it's a huge issue because the flexibility of your neck is critical for driving, you're being able to look in different directions. And so, again, that's an example of where, early intervention to try to preserve that function is key. There are some patients, rarely, who do develop esophageal and dysmotility associated with GvHD. And, even though this is, it's not skin involvement per se, you can think of an analogous process happening in the esophagus. The esophagus is a tube that's a muscle, but basically it's a very coordinated process. As you swallow, that muscle contracts to sort of move things down. And the whole chewing and swallowing process is a very highly orchestrated sort of process. And once there's fibrosis there and that motility is altered, it can be a big issue in terms of being able to eat hard foods, solid foods, or foods without a lot of liquids. And so if you have symptoms that, it feels like there's a foreign body as you swallow, you have difficulty swallowing without a lot of fluid, it may be because you have sicca symptoms, you just aren't producing as much saliva, but it may also be there may be dysmotility. And in that case, you do want to take a look and make sure there's not a swallowing problem.
Thank you. We have another question. If I was to get a transplant, what are the odds of getting GvHD for a 67-year-old male with intermediate MDS? Just looking for a ballpark.
Yeah, so, more and more patients at older ages are certainly getting transplants, which is good because you're getting the transplant because, presumably you don't have other options. And so this is a new option that's now available. But it is, considered a higher risk issue. Really, the risk is going to be entirely dependent on your likelihood of having a donor. And so if you have a sibling that's still a candidate that is a full match, then that's going to be your best potential scenario. And so the older you are, the less likely you may be to have a sibling who is healthy and a good candidate for that. But the percent of people who develop GvHD is a moving target. And the regimens that are being used to sort of prevent GvHD development in terms of prophylaxis, but also the conditioning regimens, these things are always changing. So increasingly people are getting what are called haploidentical transplants from a parent. Probably wouldn't be a scenario for you, but in that case, you're really only a half match, but these patients actually have been doing pretty well. And cyclophosphamide is being used as a preventive agent, and that seems to have been affecting the number of patients who develop GvHD. So even though I said approximately 50% of patients deal with GvHD, it's hard to predict for one particular setting because that's always changing.
Thank you. Another question is from a physical therapist asking, will orthosis or prosthesis be advised to be used in such cases? How about skin irritation? Is there a timeline when these devices can start?
Yeah, it's a great question and great to have a physical therapist on the call here. So I can't emphasize enough the value of having, a team of people to help if you're dealing with skin thickening. So I think splints to basically help preserve functions, particularly when people are sleeping at night, are one of the things that we use most frequently. Yes, there are issues with, you have to be careful about protecting the skin. And so you want, to try to avoid abrading the skin using, protective layers of, cotton and other things to try to keep the skin intact. But particularly the ankles and the wrists, we use lots of splints and orthotics to help those patients maintain their function. A question a lot of PT people always have is how aggressively to try to mobilize the joints. And so that's a difficult, no one's really done that study, how aggressively should you be massaging and stretching people? I would say you have to listen to the patient. If they are really sore and are down for a day or two after you've sort of done your physical therapy, then that's probably a sign that there's a lot of inflammation that's still active and maybe you're going a little bit too aggressively. But if their disease is, quiescent, things seem to be doing well, there's not a lot of activity, then I think stretching and range of motion and all of the other things that physical therapists are highly trained to do is really very helpful for patients with skin thickening.
Thank you. And I don't see any other questions coming in, so we'll conclude the program for today. Thank you, Dr. Cowen, for sharing your expertise with us.
My pleasure. All right, take care.
Thank you. And thank you, everyone, for joining us today. If you would like to watch this webinar again later, it will be available on our website within 2 to 3 business days. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 38 years. This concludes today's program.